humbling me with this invitation. And it is really lovely to be here. So I'll just, without any ado, I'll just start off with my presentation titled Management Paradigm Approach to Diabetic Macular Edema. So I work as a consultant ophthalmic surgeon in the UK, and I lead the diabetic retinopathy service there in the University Hospitals of Kettering. Thank you. So I don't think the talk will do full justice if I don't talk about the burden of diabetes that the world is holding at the moment. And the statistics are from the International Diabetes Federation, the Diabetes UK, and the Statista.com. India has just under 80 million people with diabetes. USA has 34.2 million, and it's rapidly rising. And they have a hidden, undiagnosed population of diabetes, which is about to explode. UK has 4.8 million people with diabetes. And if I draw your attention to the slide on the right, people will definitely agree that it's paradise. Now, this is actually an island in Tokelau in the Pacific, and they're reeling with diabetes. 1 in every 3 people there have diabetes, so it's 33.3%. In fact, that is the story with most of the nations in the Pacific Ocean. You can see all these percentages, all these islands have diabetes, quite common. The main reason being, the affluence, fast foods, and the sedentary lifestyle that they have adopted, from between 1 and 2 decades ago. These are some of the risk factors that have led to that problem. Obviously, people are developing diabetes very quickly over there, and the duration of diabetes is the most consistent risk factor for diabetic macular edema. Population studies have shown the prevalence is somewhere averaging about 6% in the type 1 and type 2, with a range depending on where you are. And the annual incidence, there's a mean of 2.7% and 2.2% in the type 1 and type 2 diabetes. The care of diabetes itself, is multi-pronged. And because of the various inputs from the faculties that are, available, like the diabetic specialist teams, the optometrists, the general practitioners, to name a few. And don't forget, the patient involvement is quite key, and we cannot do without any information technology. The next slide is probably one of the most important slides of my talk, where you see how hyperglycemia will cascade down, leading to the diabetic macular edema. So hyperglycemia itself can activate, molecular biochemical pathways. 4 have been identified so far. The polyol pathway, the age-related glycation end products, the hexosamine, the PKC, and they all lead to hypoxia, inflammation, and more importantly, reactive oxygen species through, oxidative stress. They all upregulate cytokines and chemokines. We've heard of VEGF, but there are other important ones itself: the angiopoietin-2, tumor necrosis factor alpha, interleukin 6 and 8, the intercellular adhesion molecule 1, matrix metalloproteinase, and the MCP1, which is the monocyte chemoattractant protein, which is actually upregulated more than 16 times and has an effect on increasing the VEGF as well. So all these have, a bearing on the capillaries. When you go to the capillary details, you have endothelial cell dysfunction. There are occludins and cadherins, responsible for the tight junctions between these endothelial cells. There is a fallout of that, and there's a breakup of the tight junctions. There is a loss of pericytes which occur. Pericytes, as you know, are modified smooth muscle cells, mural cells. They regulate the blood flow within the capillaries. And so a loss of pericyte means that the blood flow will be a little bit more sluggish. So the blood vessel wall itself gets weakened, and the weak walls then lead to, beginnings of microaneurysms. There is a basement membrane thickening that occurs. So you can imagine the lumen of the capillaries are becoming smaller and smaller, so there is distal retinal ischemia. There's also retinal leukostasis. The systemic hypertension and dyslipidemia on this slide are not doing any help because they take everything south direction. So there's alteration and breakdown of the blood-retinal barrier, leading to vascular permeability increases and diabetic macular edema. On the right of this slide, you'll see various treatment modalities. Really, it should be all titrated according to what goes on here and what is the main problem. So the management itself is always evidence-based, and we have got so many studies now which are actually guiding us to do what we are doing. Most importantly, we need to be a little bit more holistic. So tight control of the blood pressure, the blood sugar, and the cholesterol based on all these large studies are quite important, because they not only delay the onset of the diabetic retinopathy, they also retard the progression. Okay. You have the laser treatment, which of course we are now using for the non-center involved macular edema. ETDRS gave us a lot of guidance on that. The Diamond study is very good because it's recently published in 2022, last year. It tells us that the subthreshold laser is in fact not only non-inferior, but actually better than the standard laser that we do. I'm going to whiz through small bits about each of these studies before my bell rings. So ETDRS, of course, we know CSME is treated with immediate laser. It reduces the moderate visual loss by 50%. Ranibizumab, when it came through, it was like a magic wand. We had various studies which showed us quite nice substantial improvements. The RIDE study, for example, showed more than 15-letter improvement at 2 years. It was almost 45.7%. The Resolve study showed there was more than 60% of the eyes treated with ranibizumab had more than or equal to 10 letters of improvement at year 1. We know the other anti-VEGFs also were superior to the laser treatment. But this one is actually one of the most important things from a resource point of view. It's a great collaborative network born in 2002, the drcr.net, funded by the NEI. I'm going to give you some few important points about the protocol I, T, and U. The eye itself had 4 arms, ranibizumab 0.5 milligram with prompt laser or deferred laser, and then the intravitreal triamcinolone with prompt laser, and the sham injection with the prompt laser. It was found that ranibizumab and deferred laser was actually better. Deferring here was done 6 months after the onset of injections, and more than or equal to 15-letter improvement was seen even at 5 years to the tune of 38%. Persistent DME, it kept reducing year on year, but still at the end of 3 years, you say about 40% there. Even though the median number of injections from year 1, 2, 3, and 4 reduced from 9, 5, 2, and 1. Triamcinolone was found as effective as ranibizumab, but in the pseudophakic population. But again, it came with a pinch of salt, and salt being the raised intraocular pressure. We wanted a head-to-head between all these agents. We got the answer. Protocol T was the answer. And it found that aflibercept and ranibizumab actually have an edge over the bevacizumab arm. There was a question of when the visual acuity is less than 615, the aflibercept was found to be a little bit superior at the end of year 1, but at the end of year 2, it got equalized. Persistent DME is always a headache, and in this slide, it very clearly shows, even after the 6 monthly injections, you have the protocol I and T with the histograms showing bits of the reduced visual acuity, and this whole histogram showing the persistent DME. So really, it is just telling us that the answer is consider VEGF-independent pathways for management. Steroids, we know it inhibits prostaglandins, leukostasis, and pro-inflammatory cytokines, not just VEGF, but even the other ones as well. It enhances the barrier function of vascular tight junctions as well. Mead and Fame studies on dexamethasone and fluocinolone very clearly showed very similar results at the end of 3 years. A quarter of the patients showed more than or equal to 15 letters gain. Of course, the IOP rise was seen in both. But when Protocol U combined the dexamethasone and ranibizumab, they found there's no point in doing that, mainly because the steroids also will suppress the VEGF, and you don't need the anti-VEGF as an addition there. Faricimab is actually quite promising because it inhibits the angiopoietin-2 as well. Visual acuity gains from Yosemite and Rhine study show were comparable for faricimab and aflibercept. And this, of course, was the Q16W, which means that there were 4 monthly injections, and then the sort of interval was increased to 16 weeks, and still it was comparable. And in fact, functionally comparable and anatomically even better. So the take-home points would be, always think about holistic management, your systemic condition. Ranibizumab with deferred laser is certainly more effective in increasing the visual acuity in center-involved DME, even at 5 years. Advantage, of course, was a little bit unclear when the visual acuity starting point was less than 6/15. Consider subthreshold, think of Diamond's trial, which have been released recently. And continuing the anti-VEGF does reduce the persistent DME, but at the end, there is still a chunk of patients who are left over, and that's why there is need for VEGF-independent pathways for the management. Steroid implants, certainly very useful in pseudophakia, and also where systemic problems such as stroke and myocardial infarction accept the intraocular pressure rise in a third of them. There is no real benefit in combining the steroids and anti-VEGF. Faricimab seems to be a drug with a great potential, and it's also a solution to some of the capacity issues. Thank you very much for your kind attention.